So we're going to record. So this is a shorter lecture only because, so a couple things. Number one, I'm going to go over some stuff for the final coming up, kind of put everyone hopefully at a little bit of ease, what to do, what to expect. Is that like 40K? Probably, if it's good clarity. Yeah. Because mine was 26 when that person and I were married, and mine was only like, well, not only, I mean, I was totally happy with it, but it was only like 100 or I think 1.5 carats, but it was just amazing. Anyway, okay, back to, sorry. Just want to have a little fun. I think we all could use it. I don't know about you. I just feel, as I said, that's why it's a little dark, no makeup. My eyes are puffy because I'm allergic to this eyeliner. I don't know why I keep wearing it. No lashes. I think we're all just kind of like, whew, right? But we're doing it. And I appreciate you guys for being here. So thank you. Okay. So as I had said, so group therapy in general, I think is very important for a nurse to understand the benefits. We do run group therapy. We don't at the clinical site that I'm at currently or was at, but the VA, we run group. I run groups at El Camino, although I have recently resigned. So I mean, I've run groups for years. I personally really love it. It's like teaching. And you have to, one thing that's really important to remember about running a group, and this, I just want you to have a nice overglaze of it, is that, because I mean, if you're on a team, I think you should know what's going on. And this is mental health, and they run groups not just for mental health, but I mean, mainly mental health, and we're talking obviously about mental health, is even if you have nothing to do with it, I think it's still important that you understand why we do it and the purpose of it. And so I picked 3 short videos to watch. They're very short, animated. I thought they're pretty cute too. One's about group therapy in general, one's about family therapy, and then the other one is about CBT, which is a specific type of therapy, just so you have some idea of what that means. So I think when we say the word therapy, I'm pretty sure most of us are familiar with, talk therapy, you going alone to see a therapist. I just want to make sure that that's said, or couples therapy, or, there's talk therapy. There's so many different types of therapy that we can, choose or go to. For our purposes here, because I think we're more familiar with that, I chose more group therapy. And I wish we got to do that. Unfortunately, we don't. Especially in inpatient, it can be very challenging because we have patients that are at all different stages in their recovery of where they are. Some are brand new, some are like this morning, we had a psychotic patient that kept going off on a tangent about Jesus and Jerusalem and in no disrespect, but it's like, that's not what we're talking about, right? And then the other patients get annoyed, and then some people leave. It's very different depending on where you are, inpatient, outpatient. So I kind of wanted just to put a story to it. Now, today what we're going to do is, first of all, I'm going to talk about the final, and then we're going to watch the 3 videos on therapy. We'll take a 5-minute break, like just to go to the restroom, get some water, or whatever you need to do. And then we're going to talk about personality disorders. I have 3 NCLEX questions to go over having to do with personality disorders, and it was put under. So if you noticed last week when we weren't here, and I do really apologize, it's completely my fault. I have been, I'm done with applications. The clinical group knows. I had 104 applications to go through for the BM program. Again, not your problem or your fault. We have plenty of time before the final. So what I plan to do is this. I put 3 in there. We're going to go over them today. And the stuff that we don't spend as much time on, because this is a final, so it's comprehensive. The study guide is done. When you see it again, I think you're going to be like, That's it. Just go with it. Trust me. Okay. Please. If you have questions, please ask. I'm here for you. I'm happy to help. But just go with it. There's a method to why it's not very much. Just do what it says, please. And then I want to go, I have a book sitting here. That's why I'm looking at it. Cause I there's so much that I can talk about. I have to, if I don't stay focused, we'll end up with talking about all 10 when I really think the most important one really is borderline person. I'm having so much trouble talking. Sorry. I'm swollen up here because my dog, she licked like my mouth all night. And so, yeah, I don't know. I guess she liked the taste of the toothpaste. I did get a new one. Maybe that's why, I don't know. But so my mouth is a little bit swollen. So my apologies for that. My students are like, are you okay? I'm like, I'm okay. And then I showed them and I have all these ulcers here. So anyway, back to this. So we'll talk about, of course, there, different clusters, there's 10 different types, but we're really going to hone in more on borderline than anything. And probably that and being a narcissist, I think are probably the two most common. And then keep in mind, I'm going to add more this weekend to that NCLEX thing of the things that we don't spend as much time on, like eating disorders, personality we're doing today. And I'll look maybe one other topic and then look at those questions and I will explain them. I will post a video too. Those are all important because that helps you learn and it will be on your final. So any questions about that? And your whole study guide's up. It tells you exactly what to do, how to study, what to study. As far as the medications, I know it looks a little overwhelming. I'm not going to ask you other than like, neuroleptic, NMS or something like that for schizophrenia, like, potential death things, but I'm not going to say, what are the signs and symptoms or contraindication? It's going to be very how it normally is. I'd rather you understand the question, like what would be a potential of the gabapentins on there? What would be an off-label use for gabapentin? It's going to be things that you're used to under, like how I test. It's not going to be some, oh God, they're going to fight. Are you okay? Okay. Sorry. I thought I was choking. Honey, are you okay? Okay. Okay. I know you're okay. Get away from me. Not in the mood for you. So any questions about the final? So the final, can you guys help me a little bit with this? Because I still have not gotten a clear answer. When should I give the final? Like, no one's told me because I don't want to overlap you on a med surge day and like it's so stressful. Like, what I have not. I have not gotten an answer.
Your final is the day after med surge. So med surge is the first day of final. So I think it's everyone's, I don't know, I can't speak for everyone, but I think it's fine having it on the day that it is scheduled for.
Oh, did I already schedule it?
Well, it's scheduled through the like nursing school. They sent out an official thing. It says that we have it due on, or like our time allotted is the 9th from like noon to 1:30 or something like that.
Oh, I was gonna give you like more time, like 12 hours.
Yeah, so the day just says that it's the 9th, and then med surge is the 8th.
Okay, the 9th.
Mm-hmm.
Let me write that down real quick. I'll give you guys more time because, like I said, if you're gonna cheat, you're gonna cheat. And honestly, if you have to cheat on this, you shouldn't be a nurse. And you'll see why when you see my final. Oh, that was kind of rude. Sorry.
No,
the way I said it, but no, but for real. If you're gonna cheat, especially on this final, this is like not the one to cheat on. And can I just say something? I really do appreciate like your scores are very different, and so I don't have any. I don't know. I just trust. So the 9th final. That is correct. That is the week of your finals. It's not the 3rd week of the month.
No, yeah, it's just that
week of the 7th, right?
Yeah.
Okay.
And then have like a final after yours, but that They haven't really officially said either, so.
Okay, well, I'm gonna open it up for more time anyway, just so that you can kind of like choose when to take it. But everything's there. You're good. The only thing I need to do is post the thing on eating disorders. And really, other than that, I feel pretty good if I just get those done. We got a chat. Sorry. I have a chat. I just want to check. Then we should be good. Oh, you're welcome. Not a problem. So yeah. And if you have questions between there,
I was nervous about.
Oh my God, sorry, I pressed it. I'm about to press it for you. So yes. So other than that, the only thing left that I really need to post for you is, so we're going to go over the borderline questions today, the eating disorders one, because I think a lot of us understand eating disorders, but I do want to have some questions on it, and I will post a video attached to what I'm going to show you today, so you'll know where to find it. So you need to look at that to study for your final, please. Okay. And the medications, and then just review every NCLEX question we've ever had, every quiz and every test. And I think and the alcohol medications, which I pretty much put down, but you know, that video I made, other than that, you do that, you're golden. So I think you'll be happy. Okay. And do well. And I think you guys are so smart. Like, I mean, truly, I mean, I now that I have you in clinical too, and I hear it from your voice, like you guys are really putting in a lot of effort, and I really appreciate it. I know this is not an easy semester, med surg and all this stuff going on, and you show up, you do the work, you're dedicated. And I really think I hope that you have that pat on the back. So good job. I thought my kids were getting arrested. They were talking to cops the other day when we were leaving clinical. I'm like, Mitzi wanted to get in the car. Hi, Mitzi, I see you're here. So Mitzi was like, can I sit in the car? So I wanted to get her handcuffed. But for real, seriously, was that cop not like the most beautiful woman you've ever seen in your life?
Yeah, she was pretty.
Oh my God.
Like a Russian accent. Like
she was definitely Russian.
She was Bulgarian.
Bulgarian.
Oh,
yes.
No,
who just said she was Bulgarian? Was that the model? Jeremy?
the couch model.
I showed my clinical group that picture, sorry, today.
God,
I was like, one of my students is a couch model. Has anyone heard of this? And they're like, and they asked the same question. They're like, are his clothes on? I'm like, of course. And so I showed them. Yeah, Jeremy's a model, just so y'all know. And Mitzi said it too. Okay, good. Thank you. Okay, so we're gonna watch these 3 short videos. They're not long. They're just cute, and it really puts things into perspective. Again, I want you to have, if someone ever said to you, or you heard, or I'm sorry, if you leave this class not knowing what group therapy and family therapy, not down to a T is, but has an idea. And I don't want it just to be coming from what I'm saying, because I'm talking about the borderline personality stuff and the narcissistic. So I don't want to be talking the whole time. If you don't understand, like, have any idea what group therapy is, like, I didn't do my job. Like, this is important. So let's go ahead. We'll watch this. It's only 3 minutes, and the family one is even shorter, and then CBT, or it might be it's even shorter. They're just cutesy videos, but you can see this girl right here, right? With the little freckles.
Yeah.
Okay. So I'm going to open this up. So let's watch her.
Starting group therapy. Just the thought of sharing my struggles and feelings with a group of strangers made me feel uncomfortable. For weeks, my doctor insisted I try group therapy. She recommended a group that meets close to where I live. After talking with my sister, I decided to sign up.
Group therapy is a type of psychotherapy where several people attend the same session led by one or more therapists. These mental health professionals have specialized training in working with groups. The size of a group therapy session varies. Sessions may include a few people to 20 or more. group may be referred to as open or closed. An open group allows individuals to join whenever they are able, while a closed group requires that all participants register and begin attending on the same date. Work with your healthcare provider to find a group that fits your schedule and aligns with your treatment goals.
At first, I was worried about whether I would be comfortable sharing my feelings with so many new people. After introducing ourselves, the therapist asked us to share our thoughts. It was a relief to hear that other people struggle with the same challenges that I have. I am not alone. Over time, I started to feel more comfortable attending the meetings. As I began sharing my thoughts with the group, I felt like a weight had lifted off my shoulders. We learned from each other and shared ways to cope with the ups and downs in life.
Group therapy can be beneficial for some men and women. Participants may feel less alone when they interact with others experiencing the same challenges. Participants can also problem solve together and share success stories. If you choose to try group therapy, here are some helpful tips to get the most out of it. Be open and honest with group members. Respect the privacy of others. And always maintain confidentiality. Be prepared to listen to others and to support them in their struggles. Remember, they may be having similar challenges as you. Be patient with the process. Sharing your personal thoughts and feelings with strangers may feel awkward at first, but over time, it will likely become easier and more meaningful.
I feel group therapy has been an important part of my recovery journey. Now I look forward to my group therapy every week.
I love it. Okay, so that, it's gonna start talking. Sorry, hold on. Let me go back. So yeah, I mean, obviously that was very short, very concise, but I think it did show well about just in general, group therapy, obviously it's a group, and usually you're put into a group that will meet your needs, as far as like some people have more acuity or higher acuity. Like at El Camino, I think we have 8 different types of programs. So their groups are going to be different depending on what program you're in. Just like if you're in an addiction program, it's going to be a different topic. If you're dual diagnosis, it's going to be different. If you're in the Aspire, which is the different ages of teens, it's going to be developmentally different based upon the who's there. So it really ends up almost being like a little family. It can be, which is very supportive. Although I just want to mention before I play the next one, we do encourage that you don't, unfortunately, what can happen sometimes, fortunately and unfortunately, is that when you're not doing well, it's not always a good idea to lean on someone else. So we actually don't allow, I guess, fraternizing, if you will, like being friends. Because just imagine, like, let's say I'm not doing really well. I came in because I was suicidal, but I had no plan, but I needed group therapy because I just got divorced. I'm just making, a story. And then Nicole S is sitting next to me actually right now. So I'm going to use you if that's okay. And then Nicole S is there, and then we're becoming friends. And then I call her, but she's not obviously she's in the group for a reason too, because she's struggling with something that can actually really be detrimental as well. Because does that make sense? Like somebody, I'm not saying that person can't be there for you or give, guidance. However, we discourage that. And I want to make sure that we understand why we would discourage it. And we also don't want to be codependent, right? Like not focusing on our own recovery and what we're doing, but only focusing, because a lot of people will do that. Oh, I'm just going to, I want to make her feel better. Oh, and then that makes me feel better, which is great. But what about my treatment? Any questions about that?
Well, it could be like potentially triggering for the other person too. If you're talking about like, say it's like alcohol addiction, thinking like, oh, I want to relapse. Like, and then if you talk about relapsing, that person kind of gets triggered by like, oh, I kind of want to relapse too. Like, it could just be a snowball effect.
Absolutely. And patients all the time. I mean, I know they're still doing it, but you know, we do our best. But we do. At least I do explain why. And I think the why behind it is very important. Not just, it's kind of like, you know, sorry. My apologies. Instead of like, you know, when you're little and whoever's raising you, or maybe even now, and you just hear the word no, it's like, it's nice to have an explanation. And for me specifically with patients, I think it's really nice to have an explanation of what's going on. Not just, oh, you know, you can't do that. Well, explain why, so that the patient understands the potential detriment to their, and giving that explanation and explaining the evidence with this and that. And that doesn't mean that you can't support each other, but how and in which way. So well said. Good. Again, nice and short and sweet, right? Just I want you guys to get kind of that taste of what's, you know, out there, so that if someone asked you, it would be very embarrassing for me. Not that anyone's going to, but if you didn't understand that there's different types of therapy. Okay, why aren't you on my screen now? Not you guys, but my video. Stop sharing. Sorry about that. Maybe you should open it, Amanda. My computer's been giving me like the weirdest trouble today. I actually had a student type up the questions for me. Oh my God, quiet. Hey, Jeremy, where's your dog right now?
Right now, this second, he's in the garage.
Yeah, is he warm?
I think so. You want to see him?
Yes. You know what I want to say, but I'm not going to say it. Oh, I told my students about that too, by the way. I didn't say her name though, so. Okay, so family therapy is next.
How do you know if you're?
Is it going to be today, Jeremy, or tomorrow?
What'd you say?
I said it's going to be today or tomorrow.
Sorry.
I'm just kidding. Do you hear him? Sorry. Oh, yeah. Is your, oh, my dog just, okay, that's nice. Just peed on my chalkboard. Okay. Oh, pumpkin. So mom's not home, so dog's allowed in, right?
Yeah.
Okay, let the dog stay in. Okay, you have to keep your dog in the house during class. Otherwise, I'm going to fail you. Okay. Oh, I love it.
So cute.
Very cute. Lucas is the name, right?
Yeah, Lucas.
Very cute. Don't do what we all know what you want to do. Okay, you guys ready for the next video? Jeremy likes dogs with long noses. That's all I'm going to say. All right. Family therapy can be, wow, so important. Imagine, so if you're going through something such as addiction, because Devin just mentioned that, so that's on my mind. You're going through something, you know, there's a lot going on. Do you think your family is probably not involved at all, and they might be going through something too? And the video will talk about it a little bit more, but family therapy can be very stressful, but it can be also very, very helpful as well. It's not just, if you're suffering, your family is probably suffering too, especially watching you go through that and dealing with that and whatnot. So, okay, we have to watch this ad.
Your soap actually stops the stink. Try the butt suds test. Suds up, wash that butt crack. If your suds.
Oh my God. Sorry. Was not expected. Wash your butt crack. Okay. All right.
On my last visit to see my son, Mark, in the hospital, I noticed his attitude had improved. I was relieved to see him smile. Supporting him in his recovery journey isn't always easy. Our last several family visits with Mark were intense. My husband and I are fighting more, and I tend to lose my patience quickly with my other child.
Yep.
We'd sometimes just sit in silence. We didn't know how to react or what we could say to make his situation better. Mark's therapist suggested that we could benefit from family therapy. We initially brushed the idea aside. At the time, my husband and I thought our family didn't need any help. I assumed it was Mark who had all the issues. But the more I thought about it, the more I realized that trying to cope with the challenges of Mark's mental health condition had taken a toll on the whole family. I made a call to Mark's therapist. He recommended a licensed therapist who specializes in family therapy.
Family therapy is a type of psychotherapy or talk therapy in which members of a family attend sessions together. The family group may be as small as 2 people and may be composed of people who live together or apart. The goal is usually to improve communication and connections between family members, resolve conflict, and potentially learn about a loved one's diagnosis.
I was nervous about family therapy. I wasn't sure how my family would handle these sessions. I braced myself for the first meeting with the therapist.
At our first appointment, the therapist explained the ground rules she expected us to follow. She provided us a form which listed the rules and asked all of us to honor each one.
The therapist let each of us talk about how we communicate and how we respond when we feel angry with one another. It wasn't easy, but I'm glad we were honest with each other. After a few sessions, we planned to start working on our new communication skills. The therapist even assigned us homework. She asked us to spend an evening doing an activity together. It was a little awkward at first, but still fun.
We stuck to it, kept going to therapy and doing our homework. And it has been paying off. Things are better now, and we're less tense around each other. Managing Mark's condition is also a bit easier since we're talking more and using the new skills we've learned. My husband noticed the difference, and he started coming to therapy with us. Together, we're working to make each day better as a family.
Awesome. So that's the last video I'm going to show. I was going to show the CBT one, but I explained what CBT and DBT were last time. And really, that's not the true point of this class. It's more to understand that there are different types of therapy. That's the overall message I wanted to get out. Did you guys see what I meant by the family therapy? I don't know if any of you have been, but just as I think the mother had said, like, not knowing how to speak to your other children, not knowing how to, like, there are books for this, but like, we're not taught this. Like, how do you deal with this? How do you do this? And it can be extremely helpful. Usually we, like, for example, for couples therapy, for like a husband and wife or boyfriend, girlfriend, wife, husband, whatnot, we will also suggest to go to your own therapy. So you have your own therapy as well as your couples therapy. And that can be really important. So I think that's enough as far as, like, I just wanted you to have that nice baseline if you don't have a lot of experience with what therapy is, so that you have that baseline, or if you didn't get it in clinical. So does anybody have any questions? Because we could actually, if we don't take a break, I can go through the 3 questions, talk specifically about borderline personality disorder, have Devin talk about her experience in clinical with the patient who technically is not diagnosed, but we don't diagnose children with bipolar disorder, with borderline personality disorder. However, this person was showing traits, so more than likely will end up with the diagnoses. And I want to talk about narcissism, but really that is it's a short conversation. And that's why I said I have my book, because I have a different book than you guys have that I actually use for this class. Your book too, but this is just, it's the nice, just short pieces. So any questions about therapy in general, anything CBT, DBT, benefits, different ways that you guys had an assignment as well. So I feel good about that. Or any questions about anything in general before we move on?
Is AA considered a form of group therapy? I mean, I know
Ooh.
it's kind of like,
Ooh, that's a good question. That's a really good question. I would say that's more a support group. And let me tell you why, because they don't, that's a really good question. And no one's ever asked me that. So the reason it wouldn't be considered group therapy is because there's nobody leading the group. So when you have someone like a therapist or a nurse or someone leading a group, it's considered like a group. They do have, a secretary and whatnot, but they're not, they're also in the program and participating in the program. So that would be more of a support group, which helps many, and some, choose other avenues. Very, very good question. Excellent. You're so quiet. It's so weird because you guys, she's not quiet. She asks questions, but she's not freaking quiet. Any other questions about anything before? I think we can just, honestly, if you guys are okay with it, we can just we could be done within about a half an hour if you want to just keep going.
That sounds very nice.
I was okay, thank you. I can feel from like just looking at you, like and we will pause if you guys read my my thing. Don't let me forget though, okay? But at the end. Okay, so let me go ahead and perfect. Okay, so what we're gonna do now is I'm just gonna give you some general information. And the only reason I have the book, I'm not reading from it, it's so that I remember what I'm talking about. So in general, so personality disorders, they tend to, and remember, you don't have to write down, memorize, do anything with this. This is all going to be me, just listen, absorb it. And it's not that you can't take more than it being simplified. I'm simplifying it because I think that's what's important. And I'm going to give you the information that, in my opinion, is the most important. So in general, personality disorders are often confused with Tyler. Not with Tyler. Tyler. Shh. Shh. Oh my God. I'm sorry, you guys. He's throwing himself on the ground, throwing a fit. Like a 2-year-old. Andy, are you rapping? Who are you talking to? Your mouth is moving.
No, I'm just reading something.
Oh. Okay. So a lot of the times when people think about personality disorders, in my experience, they think of multiple personalities. And that's kind of that's not really what it is. So there are, and I don't want to get, personally, I truly don't think it's specifically important to remember, cluster A, cluster B, cluster C. And if you did your reading, you would, further understand what that meant. But like, for example, on cluster A, they have more accent I'm just going to give you an example. One is paranoid. And that just paranoid. That's like one of the actual diagnoses. And so cluster A tend to be more odd or eccentric traits. Cluster B are dramatic, emotional, and erratic traits. Those are the ones I'm most interested in. And those are the ones we are going to talk about. So whenever we say, I don't mean to laugh because it's not funny, but in mental health, we have kind of this, it's not a joke to make fun of patients because, I don't do that, but it's more like, we're like, oh, are they cluster B? Because if we hear the word cluster B, it's like, oh shit, here we go. Either a narcissist or usually borderline. Those are the two most common. And then there's cluster C, which has more to do with anxiety and fear traits, like of being abandoned. And these will come up on the NCLEX questions that we're going to talk about. They're already highlighted. The answers are there, but I will, again, this is the way that I wanted to teach it today, keep it light. So in general, so I don't lose my place. Has anybody other than Devin, I know because you had a patient, but has anyone ever really heard about personality disorders, or worked with somebody with or just kind of have an idea of, or been around someone with a personality disorder? Specifically borderline that's probably the most common, or narcissism. Who said yes?
Zainab.
And would you mind giving just a little information of you don't have to say who it is or anything like that, but just, it's nice to hear from the students, like, well, what did you see and what did they potentially have?
Well, for me, it kind of helped, like watching the video that we had an assignment on, connecting it to borderline. I texted you about how I thought it was bipolar previously.
Yep. And they get confused all the time.
Yeah. The way it kind of is when this person in specific, usually when we're sitting with her, she'll switch through like 4 moods within 15 minutes. It won't even be an hour. Like, we'll be talking, she'll be so happy, she'll be so supportive, everything will be going great. And I don't know if it's like I like show a different body movement or I say something wrong and she'll flip a complete switch and go on, like, she'll completely rage. And it'll be yelling, sometimes throwing things around, throwing things at you. And then usually when I was younger, I would like move away or stay calm. And then as I grew up, I'd like answer back, like, why are you doing this? I'm going to leave right now if you keep doing this, like, instead of just walking away. And what I've noticed is once I like confront her, she immediately turns into this, like, starts crying, starts saying, no, don't, I'm sorry, I didn't mean it.
Yep.
And then like after the crying, we'll start laughing again. And like all within 15 minutes sometimes. It's like really challenging to deal with, but I'm kind of used to it.
Thank you for sharing that. And it definitely does sound like borderline. And I did share with my group on Wednesday that a lot of time, unfortunately, and I'm sharing this coming from a therapist that told me this, who I worked with. He said, most people that are borderline, and I will explain. So brain wise, this has nothing to do with like chemicals. There's no medication that we give for personality disorders in general. However, we can treat the symptoms. So medication can be given, but it's not like with SSRIs because serotonin's off, or, you know what I mean? It's not like that. Usually most of, not all, but most of, for example, what's it called? The cluster C have to do with, a lot of them honestly have to do with trauma, personality disorders, trauma. Your trajectory of the way your brain has kind of formed has changed. So it's not like, oh, here's a medication for your borderline personality disorder. However, a lot of people have a secondary diagnoses, like with personality disorder, such as substance use disorder is very common, as well as anxiety. So they may be treated for that, which can help. However, back to what the therapist had told me, and borderline is it's a very difficult, in my personal opinion, a very difficult diagnosis to work with. I told my group they tend to love me because and you'll see in the questions that why probably I can hold a boundary very, very well, but I'm very happy and smiley, and that tends to draw the borderline to me. And however, in a second, I went from being the best person in the world to being like the worst person in the world. So what I want to do before we answer the questions is this. I am going to read specifically what the definition is. So we're really focusing. Why? You said you weren't going to bark. Tyler, treat. What? That worked. Here's a treat. So I don't think we heard you, Sean. So oh, I see. Sorry, someone's moving in, of course, right now. So Again, there's 10 personality disorders. I'm going to focus on the cluster B, the dramatic, emotional, and erratic traits. The two that I really want to focus on are borderline and narcissistic, because I feel like we see these the most. So I wanted to choose no more than 3, again, because I really want you to remember it. And these are really the most common. So borderline, I'm going to just, it's like a tiny paragraph. I want to actually just read it. So it's characterized by instability of affect, identity, and relationships, as well as splitting behaviors. Splitting meaning, like if someone were to split staff, oh, I love you, you're the best nurse ever. And then you go to another nurse and say, oh my God, I hate that nurse. You're the best nurse ever. And like splitting staff, splitting relationships. Devin, I will have you talk about your interaction as well, because it does go with this. As well as splitting behaviors, a lot of manipulation. So boundaries need to be key with those who are borderline. Boundaries. A lot of being impulsive, a lot of fear of abandonment. There's usually a lot of, unfortunately, there's trauma with borderline. That's probably one of the, if you could, if you're like doing a care map, you're going to have trauma on there. I'm not saying every single time, but usually if somebody has borderline personality disorder, they have gone through trauma. I'm not saying every single one, but it is a strong correlation. Often self-injurious and potentially suicidal ideas of reference are common and often accomplished by impulsivity. So basically meaning that fear of abandonment, we see them on the mental health unit a lot for suicidal behavior. And I still never mentioned what the therapist had told me that I worked with. He said a lot of the times and I'll never forget this because it made so much sense. A lot of the times, not all the time, but a lot of the times, oh, she could see this. Violet, you're not a boy, get off him. Come here. So he said a lot of the times people until they're like in their 50s won't even realize, because it's denial about having the disorder until they're in their 50s, and then they realize they don't have anybody because you're constantly pushing people away, or you're self-sabotaging the relationships and the friendships. And I've seen this in patients and in my family. I mean, it's so. And then the other one, I think we kind of all know what a narcissist is. And again, everything's on a spectrum. I guarantee there's 60 of you in this class, including myself. I'm sure at least half of us have, myself included. I'm sure I'm on the spectrum a little bit. Usually people that own businesses or they're like in charge of something have a little bit of it. That I've noticed that as I've gone along, but there's a big difference between having a little bit of it, which can be healthy, kind of like anxiety, other than being like this, which is arrogant, grandiose, very, very, very feelings of self-importance and the need for admiration. This part definitely not me. Lack of empathy. No way. I'm like the most empathetic in my opinion. Oh my God, I just admired myself. Sorry. Oh geez, maybe I am. Lack of empathy for others that strains most relationships, and often very sensitive to criticism. So I think that those two, borderline and being narcissistic, are the most common ones that we do see, and can be very, very detrimental to relationships, and very hard to treat. They're hard to treat. Stop. Just take the bone from him. I keep forgetting we're recording. I really hope no one else watches these but you guys, because you already know that I'm a little cuckoo. I shouldn't say that. Sorry. Cuckoo with these things. Oh, and I just dropped the book. Okay.
With narcissism, there's not really any like medication for it, right? It's more like a therapeutic thing.
I'm so glad you just said that, because I just forgot, like, hello, the biggest part that I wanted to say. Thank you. So therapy for personality disorders is usually the first line treatment. So getting therapy, self-reflection. Again, medication can be substituted with, the behavioral issues if like anxiety comes with it or something else. But no, it's not like a neurochemical imbalance in the brain. None of the personality disorders are. So unfortunately, no, it's more of therapy, and which can be absolutely helpful. I've seen it. And medication for the other side. So Devin, in 2.5 minutes or less, can you give us a synopsis of your patient? Then we'll go over the 3 NCLEX questions and then we're done.
Yeah. So I was on the kid unit, so pediatric unit at our clinical site. And I just talked to like a group of 3 who kind of like zoned in right on us when we walked in and wanted to like interact. And they really were, I think they liked having nursing students. Like Amanda had said to our clinical group, they don't think that we're there just observing them. Like we see them as people and not just, oh, they're in a mental health facility. And so they were kind of like quizzing me, which was funny. They were like asking me questions, like if I knew what we were studying. And so I said that we were just about to learn about borderline personality disorder. And the patient had said that that's what they have, which Amanda said that obviously pediatrics cannot be diagnosed. I think until 25 is when usually they'll diagnose, but shows symptoms, or I guess manifestations of having that personality disorder. And so they're asking me about it, like just quizzing me on it, saying what I knew about it. And I just said that basically I knew that it was a lot of mood instability and fear of abandonment. And when they feel emotions, they feel them very strongly compared to other people. And they had said that as well. But then they were asking me if I knew what an FP was. And I said I hadn't heard about that. I don't think it's not a medical term. It's just, I think people who are in the community of having borderline personality disorder have this term. It's called favorite person. And it's a person that they become really strongly attached to. And almost, she explained it to the extent of even obsession of like, this is my one person in my life. Like, and then she explained that they go through splitting. Like even she was telling me all this stuff that I had not even like really knew about. And she said same thing that Amanda said. Splitting is kind of like where you'll split and you'll go from like being totally like in love with them and just like they're your whole entire world to like, I hate you, screaming at them, like pushing them away. And it was kind of sad because the patient had said that the reason why she ended up in the mental health facility in the first place is because her favorite person had left her because of the emotional manipulation and the toxic environment that she was creating within the relationship. And it's like Amanda said earlier, she had suicidal ideation. So that's how she ended up there. But yeah, she was just talking about how for her personal experience and like anyone with borderline personality disorder, that splitting, once you go back, you realize what you've done, but there's nothing you can do to change it. And it makes you feel terrible because you don't want to, like, they don't want to act that way. They don't want to treat people that way, but it's just something that's their brain structure is just that way that causes them to do that. So, but I thought it was really interesting that even, I don't know how old the patient was and I wouldn't disclose that anyways, but obviously they're younger than 18. But interesting that they knew so much. Then they even taught me a lot about it. And I thought that was really cool. So yeah, that's what I learned from my patient.
And it was really good timing, right? I mean, the timing of everything and it's okay, sweetie. Sorry, my dog's choking. It was really good timing, and I'm glad because again, I like when you guys share your experiences because it makes it more real life rather than me just saying, oh, it's just about my own experiences. So thank you. And I am truly glad that this person is getting treatment early, is starting the treatment early and understands it early. On the other hand, unfortunately, a lot of people who are borderline really like attention as well. So attention seeking behavior, but we don't ignore that. We don't ever just, oh, they just want attention, right? We don't do that as nurses. I mean, I hope we don't, because one day that could really be something. I mean, oh, I'm going to kill myself. I'm going to kill myself. We get a lot of that from borderline person, not all of them. Or that sounded rude, not all of the population, but it could be that one day that you're like, oh, whatever, they always say that, but then they do. So Well explained, Devin. Thank you. Appreciate that. And Zainab, thank you, both of you, for giving some personal experience. So what I would like to do now is go over the 3 questions having to do with personality disorders. Now, this is the guide I was talking about, you guys. It says it's the week, it was last week. It says no preparation for this class, and collects questions. So I started, I'm gonna add some more down here, probably about eating disorders, and then that's it. Because I think that we've really covered, addiction, therapeutic, we've covered so much. I will get to your therapeutic videos. I'm going to start this weekend. I have yours plus 30. So that's 90 that I have to watch. And not have, well, yeah, I have to watch them. And I actually do watch them because you took the time to make them. I'm going to take the time to watch them. So that's why they have not been graded yet. Okay. Any questions before we start? I'm just going to explain these like I'm doing a video. And then if you have questions, please don't hesitate to ask. So remember, what are you going to look at as part of doing your test review? You're going to look at this, right? Because this is important and it's on your study guide. Okay. This will be posted by, I should just erase whatever, I'll erase it later. Obviously, I'm adding more, probably 3 more questions about eating disorders. So number 1, we have and I know I only have 2 questions on it. Don't ask, or 2 answers. It was I had a snafu, whatever. So a nurse manager is discussing the care of a client who has a personality disorder with a newly licensed nurse. Which of the following statements by the newly licensed nurse indicates an understanding of the teaching? So I know that I'm looking for something correct having to do with this nurse saying something about a personality disorder. So I'm looking for something right. Obviously, it's underlined, so we know the answer, but let's read number 1. I can promote my client's sense of control by establishing a schedule. Which one's better for personality disorder? That, or I should practice limit setting to help prevent client manipulation. Now, the one thing I don't like about this question, and these are actual NCLEX questions, the one thing I don't like is that it's very generalized. It doesn't say borderline. It doesn't give us like a cluster A, B, C. It's just a very generalized personality disorders. So I don't like that part. But what I do like is showing that in general, personality disorders, and if you know you have a patient that has that, it's kind of like I said earlier about if I know I have an anxious patient, I'm not going to walk in there with all the energy that I have. I'm going to be more calm, talk a little slower, and so that I don't get that person triggered. So it's kind of the same thing. I'm hearing overall generalized personality disorder. So I'm already going to need to know what to watch out for. What do I need to watch out for? Just like if someone's violent, I'm going to be more hypervigilant around my surroundings. Probably not go in the room by myself, even as a nurse, have someone with me. So it's the same thing. So in general, as an overall personality disorder, doesn't matter which one of the 10, really setting those boundaries, because a lot of them have a lot of that population. Client manipulation is a huge thing. So that's something to remember. Again, everyone is not in the same box, but as an overall, that's why number 2 is correct. Okay, then we go down to number 2. A nurse is caring for a client who has avoidant personality disorder. Which of the following statements is expected from a client with this type of personality disorder? So what I'll tell you about avoidant personality disorder is they have a really strong sense of fear of abandonment. So that makes sense why the answer is the answer. And I'm sure most of you, and honestly, I've never met anyone with this diagnosis in 14 years, never. Not saying maybe it's common in other places in the world, but here, or maybe they're just not diagnosing it. I've never, ever seen it, but I still felt that it was, why not? I thought it was important to put down just as something different. So avoidant personality disorder is afraid of abandonment. So what would I expect from that? Number 1, the client to say, I'm scared that you're going to leave me. Absolutely. That would make sense if you're afraid of abandonment. I'll go to group therapy if you'll let me smoke. Number 3, I'm laughing because that's very common. I need to feel that someone admires me. What would that be? Don't say Amanda. Narcissistic. Right? So that would be a narcissist. I need to feel that someone admires me. Or number 4, I sometimes feel better if I cut myself. That's another thing with borderline personality disorder I didn't mention earlier. So that would be borderline. There's a lot of self-mutilation behavior. So cutting, poking, burning, things like that. So it's giving different, the second one, I'm not really sure which one they're trying to go for there, just to be honest with you. And my book fell on the floor, so I'm not picking it up. But it makes sense, right? Number 1, abandonment, avoidant personality. So that's how I remember it. AA. Any questions about that? Okay. Number 3, now we should all know because we talked about this. So borderline personality disorder. So we have this client who has this diagnosis, states to the nurse on the evening shift. I have to read it from the beginning. Sorry. A nurse is caring for a client who has borderline personality disorder. The client states, the nurse on the evening shift is always nice. You are the meanest nurse ever. The nurse should recognize the client's statement as an example of which of the following defense mechanism. Is it regression, splitting, undoing, and identification? Students tend to like number 1, regression. It's splitting. So we know the borderline personality disorder tends to have that manifestation and symptomology of splitting. So and that's actually extremely common. And one way we can tell, it doesn't have to be in this exact way, but how we can kind of pinpoint traits of personality or borderline. And the last thing I'm going to say before I pause the recording, so I can ask you guys a question, is if we're in a meeting, like a staff meeting, talking about, are you eating food? Okay. Is if we spend so much time talking about a patient, there's almost kind of, and I don't mean this to be rude, it's almost an underlying joke. If we spend, let's say on a normal, not normal, but just on like a patient, normally about a 7-minute check-in. How are they doing? Are they going to their meetings? Are they doing this? If we get to a patient that has borderline personality disorder, usually we talk about them for like 20 minutes. And it's kind of this underlying joke of, okay, we know we're talking about someone who's borderline because they're taking up so much of our time. Because in general, this specific disorder does take up a lot of time because it's all about them. And I'm only saying it just kind of straight up just to get the point across. And I'm not saying they're bad people or anything like that, but the symptomology can be very exhausting. It can be very exhausting. So yeah, this is up for you. Please, I hope that you guys understand it. Again, I'll add 3 more. And there's 6 questions that you know for sure will be on your final. So now let me just stop sharing and stop recording. Well, first and foremost, before I stop recording, does anyone have any questions about what we learned about today? Pretty straightforward. Okay. So I'm going to stop the recording.